For the next session, it is my honor to introduce Professor Muhammad Miftahussurur to join the session of ASMG and HSI on the topic of global shift in the Helicobacter pylori and gastric cancer management. Professor Miftah is currently gastroenterologist in Department of Internal Medicine, Faculty Medicine of Università Erlangga. He is also chairman of Helicobacter pylori and Microbiota Study Group, Institute of Tropical Disease, and vice rector of Università Erlangga for internationalization, digitalization, and information.
And for our next chairman of the session, she needs no introduction, Professor Varocha Mahachai. She is distinguished clinician and academic leader, renowned for advancing Helicobacter pylori management and gastric cancer in ASEAN. Please give a warm welcome to both of our moderators. Thank you.
Welcome to the Healthy Stomach Initiative meeting. This group has formed with people who have interest in gastric diseases function, start from in the European community, and we extend to be an Asian chapter. So we organize this almost every year, and also will be at the APDW in next 2 weeks. So today, Dr. Miftahussurur from Indonesia will join me to share the session. We have 3 outstanding speakers. It's focused on, as I say, it's a special interest in the stomach diseases. So today will be on Helicobacter pylori and gastric cancer management. We have prominent speakers, and the first one will be Dr. Quach. He's from Vietnam, and he will speak on the important issue of antibiotic resistance in Helicobacter pylori. It's a global trend and transitional challenges so as it affect the treatment of Helicobacter pylori. So please, Dr. Duke.
Good morning, everyone. Thank you, Mr. Chairman. First of all, I would like to thank Professor Varocha and Professor Ratakon for inviting me to this important meeting. So my talk today will be on the antibiotic resistance in Helicobacter pylori, global trends and translation challenges. So in my talk, I will focus on two points. The first is about antibiotic resistance of Helicobacter pylori, and I will discuss about the global trends and then our region. And then I will discuss about translational challenges in the management of Helicobacter pylori. This map is to show the prevalence of Helicobacter pylori over the world. And you can see here that the updated data show that compared to the past, we have more than half of the population worldwide affected by Helicobacter pylori. But recently, we have some dramatically decreasing in prevalence. But you can see here that the majority of the area and the country still have the prevalence about, I think, 30 to 45%, especially for the Asia-Pacific region and the Southeast Asian region, both in adults and in children. Now we look at the primary antibiotic resistance rate of Helicobacter pylori, and I will narrow down and zoom in from the global scale to the Asia-Pacific scale, and then to the Southeast Asian region according to our recent survey across the 10 Southeast Asian countries. So this slide to show the global primary antibiotic resistance rate, and we can see over the last 10 years, there's some significant change in the antibiotic resistance rate of Helicobacter pylori. Metronidazole still increasing, and we have some emerging increase in resistance rate of clarithromycin and levofloxacin. Regarding to tetracycline and amoxicillin, we can see here that over the last 10 years, it's still low and stable. It's also important to look at the children data. I think that we have a few children data compared to the adult data. And again, this slide to show that according to the global landscape in the children, we have a similar trend of antibiotic resistance, increasing with clarithromycin and metronidazole worldwide. But for amoxicillin and tetracycline, they're still low and stable. This slide to show the antibiotic resistance rate distributed across the different regions and continents. And it was published recently in the Gut. And you can see here that the red show the higher prevalence up to 15% or more. And we are facing with the problem with clarithromycin, levofloxacin, and metronidazole. And there's some happy to see that amoxicillin is still stable, but there's some difficult to see that in the Asia Pacific region, the Vietnam is in the red color. That means we have increasing amoxicillin resistance rate compared to other countries. And this slide to show that the highest concern is in the Africa. So we are narrowed down to the Asia Pacific region, and it's a very nice study from Professor Liu group and Professor Hong group. We show that similarly with the global landscape, we also see that the increasing resistance rate of metronidazole. And again, we have clarithromycin and levofloxacin in the increasing trend. And the primary resistant prevalence of tetracycline and amoxicillin are still stable and low. So now I would like to share our latest information according to the expert survey group across the 10 Southeast Asian that we have just collected. And I would like to thank all the participants of this consensus that we have just finished yesterday to contribute and provide this data. So when we look at clarithromycin resistance, we can see here that when we look at the prevalence, the color of you see of 15% or more, that means the threshold that we can consider triple therapy with clarithromycin based or not. So the majority of the country in our region have a higher rate of 15%. There are some countries with lower than that threshold, including you see that Myanmar, Malaysia, but I think that it's still very dangerous to see that the resistance rate are now approaching 14 or 15% already. So for primary metronidazole, as you see from the global scale or the Asia Pacific, again, it's a very dangerous. But it's very important that to address that when we combine with Bismuth, we can overcome the metronidazole resistance by this combination, or we use the higher dose up to 1,500 or 2,000 milligrams to overcome this primary resistance rate. So regarding to the primary levofloxacin resistance and amoxicillin, again, we can see here that levofloxacin is increasing. And for amoxicillin, Vietnam is now more than 25%, already up to 28%. We have some intermediate amoxicillin resistance rate in Cambodia, in Indonesia, from 5 to 10%. And for the rest country in our Southeast Asian region, less than 5% or zero. So another important point when we look at the left side map, that the primary multi-drug resistance defined as the resistance to at least 2 or more key antibiotics to Helicobacter pylori. Again, we have some few data from Myanmar, from Cambodia, Vietnam, and the Philippines, which show that we have the prevalence of up to 15% or more. And another important point to address that the primary tetracycline resistance rate is still very low. We have no resistance rate in the majority of country, and in the Indonesia updated that the resistance rate is about 4.4%. So it's still a very useful and useful antibiotics. So now we look at some trends in the national scale, and I would like to share some data from Professor Ang in Singapore. And over the last 20 years, again, it's a mirror the trend of the global landscape and the regional landscape that we have an increasing rate of clarithromycin and levothyroxine, but tetracycline and amoxicillin are still stable. And this is also a very nice study from Professor Rathakon group, which showed that what happened to Helicobacter pylori and resistance over the last 20 years. And again, it's very important to see that the rate of metronidazole, levothyroxine, and is still very trouble. This is the resistance rate not for primary, but combined primary and secondary. So in the gray bar, you can see here that the multi-drug resistance increased from 4.2 to 27.6. It's very challenging. So for the second part of my talk, I will discuss about the translational challenges in Helicobacter eradication. So now the bacteria is considered an infectious disease. So according to the management, it would be ideal to have antibiotic sensitivity testing before. And we have some study in our region to show that this slide again from Professor Rathakon group, which mentioned about the management of Helicobacter pylori treatment failure. And they have three groups, no ASD, that means antibiotic sensitivity testing. And in the green one, they have the ASD after the first line therapy. And for the blue bar, the blue line, you see that ASD after the second line failure. So for the no ASD, you can see here that up to 5 times that empiric treatment, the failure is still very high, 50%. If we consider about ASD early, that means ASD after the first time failure, so we can see that we can get up to nearly 100% eradication rate after we have the ASD result. And if we in the blue bar blue line, if we have ASD but we order the test later, so we can improve and increase the eradication rate up to nearly 100%. But it takes time and very, I think that very costly, I think, because it's up to 5 times that we have to try in order to get the eradication. And it's just not the eradication rate. It's also very important to talk about the cost effectiveness, one of the big issue in Asia region. So it's also another study from Professor Rathakon group to show that the cost effectiveness when we have ASD and without ASD. And again, in this study, they have a 3 group, no ASD, early ASD, defined as ASD after just 1 time attempt, failure attempt, and ASD, the third group is ASD after treatment failure. And when we look at the total cost, including first-time medication, culture, subsequent hospital visit cost, and other subsequent medication, clearly we can see that the cost effectiveness is highest in the early ASD compared to the no ASD or ASD after treatment failure several times. So I think that is very interesting. And not only that, when we look at the subsequent failure to the whole population, it's also very important issue to consider here that the multi-drug resistant rate, if we do not have ASD and we try it after several times, is much higher, 32.8% compared to 8.3% after the early ASD. So I think that is also important point that we should consider. But when we think about the ideal treatment that we should have a tailored therapy that will be based on ASD, there's some other evidence to show that we are not in the ideal situation which we have ISD. And this study to show that it's the meta-analysis from 34 studies involving nearly 10,000 patients. And clearly we can see that we can significantly improve the eradication efficacy up to more than twice time. But when we look at successful Helicobacter pylori eradication achieved with tailored therapy, so it seems that it's not optimal. 90% of the, we set the threshold at 90%, only 44 of the studies show that. And if we set the threshold of eradication successful is 95%, only 6 studies. So the tailored therapy should be something that we should also consider and improve in the future, I think. Now we go back to the Asia Pacific, and we would like to discuss about the Southeast Asian region problem that we have are now facing with the multi-drug resistance with several failure according to previous slide that I showed. But it's also very important to look at the medical resources in the region that we have. And according to our previous survey, when we look at the resources of Bismuth, PCAP, and ASD tests in the Southeast Asian countries, when we stratify into 3 groups, low clarithromycin less than 15%, intermediate, that means 15 to 20%, and high clarithromycin, that means more than 20%. So clearly, when we look at this, I think that it's very important to see here that the available of the test is very challenging. And you see here that only about half of the big hospital in the region have the test. So how we can do and we manage that, I think that the empiric therapy should be also a very important option in our real life practice. So we have to base on the stronger anti-acid depression as well as based on the other option like Bismuth combination. But when we look at Bismuth, again, I think that for high clarithromycin country, I think that we are very happy that 80% of the country with high clarithromycin country can have the drug. And for PCAP, it's not available. As you see here, only 23%, but it's the majority is in the intermediate or low clarithromycin countries. So I think that we can, based on that, to decide which is the local resources that we can use to overcome the challenging situation. This slide to show what the American colleagues recommend. And for the treatment naive, as you see here, that they recommend the optimized Bismuth quadro therapy. And for the treatment experience, there's no strong recommendation, but strategic empiric treatment like optimal Bismuth quadro therapy or rifabutin triple therapy. And for penicillin allergy, so the Bismuth quadro therapy is the recommended treatment. In Vietnam, I would like to share what we have, especially in the case that we have a very high rate of resistance rate of amoxicillin, metronidazole, levofloxacin, and clarithromycin. So the first choice in the country is the PPI, tetracycline, metronidazole, and Bismuth. And in case that we do not consider that the second option is that PPI, amoxicillin, levofloxacin, and Bismuth. And if we fail, then we can change on the opposite arm if we do not have the ASD machine, and we can consider the test after 2 times of failure. Why Bismuth is considered here? Because it's available in high clarithromycin resistant rate, and there's some study to show that it can help to overcome the resistance of levofloxacin and clarithromycin. For example, in this study, we show that the comparison between levofloxacin and Bismuth and levofloxacin, I can see here that for the susceptible strain, there's no significant difference. But for the resistant rate, strain of levothyroxine, there's some significant difference. And when we combine levothyroxine with Bismuth, we can overcome and increase the the eradication treatment up to 10%. And there are also some meta-analysis to show that for dual clarithromycin and metronidazole resistant strain, we can increase the rate of eradication successfulness using this combination. So for the PCAP, we have several studies, and I think that we have a lot of evidence now, and I would like to share one of the nice study meta-analysis from Professor Fontainer. And he compared different treatment with lantoprazole-based clarithromycin. And this slide I think it's very nicely show that vonoprazan-based tripotherapy or even dual therapy can have a very good effectiveness compared to Bismuth quattro therapy, as you can see here. And it not only in the whole global landscape, but also in the Western country. And this slide to show that recently we have a Taipei global consensus when we have a prominent professor, Professor Liu, will discuss about it in detail. And I will skip that. And for the future, I think that when we are in the era of antibiotic resistance, there may be some other way that we can consider, for example, potential therapy target non-antibiotic drug, again, Helicobacter pylori, like targeted urea, Chandler, adhesion factor, or drug delivery into gastric mucus. And the future, besides what Professor Francis Chan mentioned this morning about the use of probiotic, I think that maybe other options that we can use non-antibiotic, including probiotics for Helicobacter eradication. So, Mr. Chairman, ladies and gentlemen, for my conclusion, I would mention that the global antibiotic resistance of Helicobacter pylori is increasing, and particularly to clarithromycin and levofloxacin, while resistance to tetracycline and amoxicillin remain relatively low and stable. And the lack of reliable ASD method is the majority in many regions, including certain Southeast Asian countries. Empirical treatment should be applied with great caution based on the local resistance pattern. And the strategy to overcome these challenges included tailored regimen, including using antibiotic with low resistance rates, such as amoxicillin and tetracycline, combining with Bismuth, or we use a stronger acid suppression like PCAP to enhance efficacy against resistance rates. And the current recommended first-line empiric treatment we can consider including the Bismuth quattro therapy and PCAP-based regimen. And finally, developing therapeutic targets for non-antibiotic drugs against Helicobacter pylori infection represent one of the promising directions for the future. Thank you very much for your attention.
Thank you very much, Dr. Duke. And we give Q&A at the end of after the three speakers. So I would like to ask Dr. Miftah to introduce us next speaker.
Okay. Next speaker is Professor of Medicine and Consultant Gastroenterology from University Sains, Malaysia. He have 300 papers in high journal impact with some awarded from the Malaysia government for also Stanford top 2% in world in their respective field. Is Professor Yeong with optimizing H.pylori management, evidence-based pathway and putative direction, future direction. Please, Professor Lee.
Very good morning, everyone, and thank you so much for the very kind invite and the kind introduction. Thank you to Prof. Varocha, as well as my good friend, Prof. Radakon, for the invite to this fantastic meeting. Now, I was given a task also to optimize the H.pylori management, and I think Duke has done a fantastic job, and hope to provide some overview and expand on what Duke has already mentioned. I think the first thing is we need to start thinking, should we really kill a Helicobacter pylori or not? Because if we are very convinced that a good Helicobacter pylori is a dead one, then we probably will go all out and eradicate this particular pathogen. And is there a one-size-fits-all approach? And lastly, what can we do better? Now, we all know that there are many diseases caused by Helicobacter pylori, including chronic gastritis, atrophic gastritis, as well as gastric cancer. There are also other extra gastrointestinal cancers I can show over here, including idiopathic thrombocytopenic purpura. But other than that, there are many other conditions nowadays being recognized, being associated with Helicobacter pylori. We also remain very concerned about gastric cancers. If you look at the GloboCan data, it's now the 5th most common cancers and the 2nd most common cause of cancer death. Now, WHO has classified H.pylori as class 1 carcinogen, obviously for a reason, and where they are still seeing a lot of cases being reported worldwide, accounted for 5% of new cases worldwide, and most of the burden of disease remain within this region, including Japan, China, and also Korea. One of the observations also is that the prognosis for these cancers are typically worse also in this region. Now, the good news is that if you look at meta-analysis out there, eradication of Helicobacter pylori can prevent gastric cancers. You were to look at this group here on the top, comparing eradicated versus not eradicated. The meta-analysis obviously favors eradication therapy, and comparing successful versus unsuccessful regimen, it does favors successful treatment. So when you put all this data together, you are giving us a protective effect of almost 54%. Just want to share some lessons from a low prevalence population where I'm from. These are just among some of the papers that we have published from this region in the northeast part of the peninsular Malaysia. And we also have data from the chairperson here, Professor Miftah, where certain parts of Indonesia also reported very low prevalence of Helicobacter pylori. Now, in our region, we reported a zero prevalence of Helicobacter pylori less than 5%. Now, the good news is if you have very low prevalence of Helicobacter pylori, again, we can demonstrate very low pathology, especially gastric cancer. In fact, my surgeons they cannot do their job because they cannot have any learning curve on management of gastric cancer. So that is one of the observation from this particular region. But I think one of the learning point is what are the factors that account for why this population has low prevalence? And what we found obviously would include factors like having clean water, hygiene, and sanitation. There are certain protective antimicrobial diet or functional food that have been taken by this population. Also, we have less virulence factors, and there's also certain protective gene polymorphism, like I've listed over here. Now, why are these important? Because when we are thinking about optimizing eradication, we also need to start thinking about what are some of the environmental factors, what are some of the lifestyle factors, what are the diet that can potentially help us to also optimize the management. What about vaccines? This is another question that some of you may ask, is there anything new? So we published this particular editorial a while ago, back in 2019. There are really currently no any advanced vaccine candidates with only one single vaccine in just phase 1 clinical trials. Let me just go back here again. Only one in the phase 1 clinical trials. Now, the virulent factors are often used as a recombinant protein in the vaccines, but they only induce weak immunity, not very stable, and there's always been delivery issues and as well as a safety concern. If you remember probably the most effective data come from this particular study published in Lancet in 2015. There's one oral recombinant vaccine where they use urase B and enterotoxin B given in children 6 to 15 years old, and it did report an efficacy of 77% at 1 year and 55% at 3 years. But subsequently, you don't see any phase 3 trials, and there are potentially side effects from the use of bicarbonate. So the key question here is how to improve the current eradication rate. I would probably put it under the 3A framework. 1A is antibiotics, 2 is acid inhibition, and 3 would be on adherence. We have heard a lot about antibiotic resistance from my colleague Duke. We have seen this. Many countries have crossed the so-called threshold for antibiotic resistance, and in my country it's also similar. In fact, we are seeing metronidazole of resistance up to 59%, levofloxacin 3.3%, and clarithromycin, because we still use a lot of triple therapy, and clarithromycin is one of the main components, we are already seeing a borderline resistance at 14.8%. Again, Duke has mentioned some of the potential ways of overcoming this. One obviously would be to consider bismuth-based therapy, but we all know that bismuth is not readily available in many countries, and there are a lot of side effects associated with the use of bismuth. If you ask your patient when they take bismuth, they will tell you all kinds of side effects, GI side effects predominant, but it's not a very easy drug to take. Also, you may want to consider other antibiotics. Yesterday, we did have a bit of a discussion on citalfloxacin. I think Ken has vouched that it's probably the most potent quinolone out there for Helicobacter pylori. And it also, not just potency, it also has an effect on overcoming antibiotic resistance. So this is something to consider. Maybe a simple and effective regime is what we need. This was a paper from my colleague Alex Liao and also the late Professor Goh, where they actually looked at whether the high-dose dual therapy just consisting of amoxicillin and a high-dose proton pump inhibitor. In this case, it's a proton pump inhibitor. Whether does it, when it compared to a typical 14-day standard triple therapy, whether does it helps to improve the eradication rate. If you look at this particular table over here, you can see that when we compare the two regimens, there were no significant difference, indicating that both achieve similar eradication rate. There's also a study from Japan where they, instead of using a PPI, they substitute with a PCAB, and they also found that when they have a high-dose PCAB with high-dose amoxicillin, it does have very similar eradication rate comparing with the PCAB-based triple therapy. Acid inhibition is a key component of eradication therapy. Now, the reason is we know the acid inhibition will increase the gastric pH, and this will then increase the population of dividing Helicobacter pylori. In fact, Helicobacter pylori grow best at the pH of 5 to 6. And because of this reason, the bacteria will become more susceptible. And this will then trigger the Helicobacter pylori to enter into a replicative state and therefore more susceptible to antimicrobial agents. We know also that when you give a PPI therapy, not all of them will have similar effect when it comes to eradication. For example, in this study comparing esomeprazole and also lansoprazole, they only achieve 76.9% with esomeprazole, whether with a so-called PP analysis or per protocol analysis, and with intention to treat analysis only like 69.4%. This is far away from the 90% that we wanted to achieve. So likewise, lansoprazole, only 79.8% and 73.9%. Now, what's the uniqueness of proton or PCAP. Now, vonoprazan is one of the PCAP, and I think we have been talking a lot about PCAP, so you're still going to hear a lot more PCAP today. Now, if you look at the curve over here on this graph, you look at the graph on your right side, you can see that vonoprazan is equivalent to very high doses of proton pump inhibitor. You look at this table here, if you can achieve a high dose of equivalent dose of PPI, you can achieve almost 60% of cure rate. So this was a meta-analysis that my friend Prof. Ari Sham has shown. We published this in JGH back in 2022. It does show that from this meta-analysis using 9 RCTs with almost 900 over patients, the pool eradication rate for a first-line treatment can be achieved at 91.9% compared to 79.9% for a proton pump inhibitor. Now, even though this meta-analysis also looked at second line and third line, but there are very limited studies available when we were doing the meta-analysis for second line and also the third line. More recently, we have a newer PCAP coming to our shore, and this is the tocoprazan or KCAP. Again, I do have some limited experience with using this particular PCAP. Just report that there are some studies available out there for this particular compound. For example, I've shown here in this slide, this was a phase 3 randomized double-blind active control comparing with lansoprazole given twice a day for 7 days, and the endpoint was the eradication rate for Helicobacter pylori. Tocoprazan also has another paper looking at a more real-world evidence comparing 7 days versus 14 days triple therapy. If you were to look at the two studies, one is the eradication success is similar between tocoprazan and lansoprazole, definitely non-inferior based on per protocol analysis. But in the real-world eradication success, as is shown over here, there are actually indications to suggest that there is a better eradication success when we were to use a 14 days compared to a 7 days regimen with a similar adverse event rates. Now, what about adherence? Very often when we prescribe a proton pump, a triple therapy or even eradication therapy, we often neglect whether or not we achieve our report cut. So if you were to aim 90%, have you done your own audits? Did your patient actually achieve 90% or not? If not, did you try to find out why? Is it because they have intolerance to antibiotics? I have prescribed to patients and we try to give a phone call to a patient and find out what have they done after being prescribed antibiotics. And some of them, typically when they experience side effects, they don't come to doctors. And very often they either stop the medication themselves, and then when they come back to my clinic, they say that, sorry, I just couldn't tolerate the antibiotics. Also, did we try to explain to the patient that, look, antibiotics you are giving are very high doses. It may induce side effects, and these are the potential side effects that you have. If you do have this side effect, what should you do? And do you have a follow-up call to patients? What about giving probiotics earlier just to reduce that potential GI side effects? So very often I think as doctors, if you know that your tried and tested regime can achieve 90%, then we should try to stick to that. Very often, we also need to think that whether the regime is simple to use, is effective with low resistance, and whether there is also a strong acid inhibition. So I do hope that you may remember this 3A and use the 3A framework in your patient. Now, what does the future hold? I don't hold a crystal ball, but we will try to discuss and see what can the future hold. We have heard fantastic talk from Francis on that microbiome and how to stay young. In the stomach itself, for a long time, we never think whether there is any other bacteria beside Helicobacter pylori just because of the strong acid. But we now know that the Helicobacter pylori itself, they also have other microbiome, including lactobacillus. And with the presence of Helicobacter pylori, it may actually reduce the diversity and the richness of the microbiome environment. There's also more recent evidence suggests that in gastric cancer, there may be other pathobiome that may work together with Helicobacter pylori, causing gastric cancers. And this pathobiome will include Streptococcus aeruginosus and even the one that we know, Epstein-Barr virus. As I mentioned, these two pathobiome may interact with Helicobacter pylori, causing carcinogenesis through interaction with the host cells and also causing tumor microenvironment changes. We also know that if you were to give antibiotic after eradication, it can also induce dysbiosis. And some of these dysbiosis, as you can see in this graph here, it can persist even beyond 6 months. They do not return to baseline immediately, although some may have just a very short-term effect, for example, on the proteobacteria. And the dysbiosis is the very reason why some of your patients may have diarrhea, may also have other potential metabolic effect like weight gain. So modulating the microbiome is really what I believe could be the future. As I mentioned, H.pylori can induce notable gastric dysbiosis. It can be restored through eradication. And the probiotic can restrain Helicobacter pylori-induced dysbiosis. And this particular pathway here are potentially what can be used microbiome in order to help us achieve better eradication. Just one or two slides more to go. The other interesting aspect of using probiotic that is it can help to reduce eradication resistance. For example, in this particular study, when you add Saccharomyces boulardii, which is one of the yeast-based probiotics, together with antibiotics in eradication therapy, it does help to reduce the abundance of what we call antimicrobial resistant gene. Now, the interest is always about fecal microbiota transplantation. If you look at this particular systematic review, there are some small preliminary pilot studies suggesting that FMT alone, comparing with probiotic, may have some effect on eradication. You look at this particular table here on your far right, just by giving probiotic alone, it can achieve almost 14% of eradication. And on the other side of the table, FMT alone can achieve 40% of eradication rate. What about adjunctive treatment? In the middle of this table, if we were to combine high-dose dual therapy with FMT, it also will have very similar eradication rate, but the GI side effect were less. Just want to share some local experience. I borrowed this particular slide and also study from Ratacon. I believe this is also a poster that will be available in the meeting today. He did share with me that by combining vonoplastin therapy with an encapsulated fecal microbiota transplantation, it is a useful adjuvant for Helicobacter pylori eradication. This is what he termed as a FMT-HP trial. And this adjuvant therapy can be associated with less GI side effect and also associated with better quality of life. So watch out for this study. And in the last meeting, he did also presented this where in someone with a multiple Helicobacter pylori treatment failure, it can be even achieve some effect from just doing fecal microbiota transplantation. So this is an area that is also obviously worth to explore. Just for a conclusion, a good Helicobacter pylori is a dead one. This is what David Graham has coined. Vaccine is probably a dead end for now, you need to achieve an excellent report card, and this is what I would say the 3A framework. And last but not least would be on the role of microbiome modulation, and I believe there is a future potential, but we do need to do more research confirming this observation. With that, thank you very much.
Thank you, Professor Lee. Of course, many questions we related with all our excellent speakers. However, the time is up, so we will close this stage. Thank you very much also to Professor Mahachai for also leader for this session. Thank you very much. Good.